I start by paying tribute to all my teachers who have taught a lot in medicine and radiology without no technological aid and no PowerPoint in the days that they taught us a lot. Now, these are words of the Apple co-founder Steve Jobs, who incidentally was one of the eminent personalities who succumbed to a malignant pancreatic neuroendocrine tumors years back. In today's talk, I'll be giving you an overview with regards to the imaging as well as briefly touch upon management and the background of all these neuroendocrine tumors, specifically with regards to pancreas. Now, neuroendocrine tumors are generally a vast set of tumors that can occur anywhere in the body, which have a histopathology that shows a neuroendocrine differentiation. So your carcinoid tumors, which are relatively more common that occurs in your lung, your thymus, or anywhere in the body, comes under this ambit of neuroendocrine tumors. So also your pheochromocytomas, your NETs that are in relation to your bowel, including your appendiceal tumors, are also part of your neuroendocrine tumors. The less known varieties of your medullary thyroid tumors and your skin cancers, that is your Merkel cell carcinomas, also come under this ambit of your neuroendocrine tumors. In today's session, I'll be taking you through pancreatic neuroendocrine tumors, which relatively form a minority among this neuroendocrine tumors, only about 7% of all your neuroendocrine tumors. So even in the pancreas, these neuroendocrine tumors are relatively very rare. When compared to your adenocarcinomas, these are very rare, accounting for only 2% of your pancreatic cancers. In general, your pancreatic adenocarcinomas usually arise from the ductal epithelium. And earlier, there was a misnomer that these neuroendocrine tumors were actually arising from islet cell or endocrine cells, and they were referred to a terminology of islet cell tumors. But lately, with better understanding of the pathogenesis, it was found that these neuroendocrine tumors actually arise from the pluripotent ductal epithelial cells, which show neuroendocrine differentiation. Now, majority of these lesions are sporadic, with 10% being associated with genetic syndromes. Now, when compared to your larger majority of your pancreatic adenocarcinomas, which we generally term as pancreatic cancer, these neuroendocrine tumors are relatively benign. They are having a low, relatively well-differentiated morphology, meaning that they have got a better prognosis when compared to your adenocarcinomas, which overall has a very poor prognosis in terms of management and life expectancy. Now, many of these tumors, neuroendocrine tumors, are detected very earlier on at a younger age, and thereby your treatment and management actually make sure that these patients survive for a longer time when compared to your adenocarcinomas. Now, in today's session, I'll be taking you through the classification and the genetic basis before dealing with in detail the imaging part. Also, the associated syndromes that are seen in relation with neuroendocrine tumors of the pancreas, before touching upon differentials and management, before concluding with the recent developments in this area of imaging. So the classification that we follow for pancreatic neuroendocrine tumors is presently the 2017 WHO classification, which brings all your pancreatic neuroendocrine neoplasms under the terminology pertaining to pancreas. In general, this is divided into two types. This has got a well-differentiated pancreatic neuroendocrine tumor, what is referred to as a pan-NETs, which has got grade 1, grade 2, grade 3, and the poorly differentiated pancreatic neuroendocrine carcinomas, which is the pan-NECs. Now, this pan-NECs have got histologically large cell and small cell types. And in addition to these major groups, two groups, you also have something that is similar to your collision tumors that occur in your adrenal, wherein you have tissues that have both endocrine as well as your non-endocrine differentiation. So they have mixed tumors, which are called as NENs. And histopathologically, they have got the ductal and the acinar type. Now, based upon the clinical syndromes that these tumors produce, they can also be classified based on the endocrine function into either a functioning NET or a non-functioning NET. The functioning NET depending upon which particular hormone or clinical syndrome that they produce. Coming to the functioning NETs, generally they form around 30 to 40% of all NETs, with larger majority of NETs actually being non-functioning. The most commonest functioning NET is the insulinoma, which has classical symptoms because of increased insulin secretion. You have documented hypoglycemia, you have symptoms of hypoglycemia, which are relieved on administration of IV glucose, which is termed as a Whipple's triad. Naturally, because your insulin is high in serum, you expect your glucose to be low and also your C-peptide to be high, which is not the case if you are having exogenous administration of insulin. So insulinomas in general are benign, well-defined tumors, which are the typical arterially hyperenhancing, well-defined small lesions that can be distributed anywhere along the pancreas. The second most commonest functioning NET is the gastrinomas, which usually present with abdominal pain or gastritis symptoms in addition to diarrhea and ulcers. The gastrin levels in serum will be high, and because they have hypersecretion of your gastrin, there will be irritation of the gastric mucosa, which results in CT for a thickening of the gastric rugal folds, in addition to thickening of the esophageal wall, as is evidenced by esophagitis. So this is the clinical syndrome of gastrinoma that is referred to as the Zollinger-Ellison syndrome. You have the rest of the functioning neuroendocrine tumors, which are more commonly malignant compared to the previous two. So glucagonomas are associated with diabetes. They have a specific type of dermatitis, which is the necrolytic erythema migrans. They have weight loss with anemia and thrombosis in addition to depression. Naturally, glucagon will be high with glucose levels to be high as well. The relatively rarer VIPoma usually has the clinical syndrome referred to as the Werner-Morrison syndrome or the watery diarrhea, hypokalemia, echlorhydria syndrome. And as previously mentioned, they are often malignant and present with diarrhea with hypokalemia in serum. Now, the differentiation basically among your functioning tumors, specifically in patients who present with diarrhea, the differentials are mainly your gastrinoma and VIPoma. And very often your evaluation for gastrin levels and VIPoma may be limited in many of the setups. So what clinicians usually do is that because gastrinomas tend to secrete your gastrin, which is basically something that acts in the stomach, they put patients on your Riles tube aspirate so that all the gastrin that is secreted is actually pulled out. So if patient has relief of diarrhea following a Riles tube aspirate, it means that you are mainly dealing with a gastrinoma. Whereas in case of VIPomas act distal to the second part of duodenum, where your Riles tube aspirate may not actually function. So in those cases who present with an pancreatic NET, which has diarrhea as its main symptom, you can even clinically make a diagnosis whether you're dealing with a gastrinoma or VIPoma better. The rarest of these are the somatostatinomas, which usually have associated diabetes, gallstones, steatorrhea, and hypochlorhydria. You also have, because these tumors arise from pluripotent ductal epithelium, you can have rarely tumors that secrete ACTH or any of the other hormones, including calcitonin, serotonin, parathormone, and the related clinical syndromes that these hormones have. Now, as a radiologist, it is important that you also be aware of which is the commonest location of these pancreatic functioning neuroendocrine tumors. So to make it easier, if you can remember that insulinomas are the most commonest lesions, and they are usually distributed anywhere along the pancreas. They don't have a specific predilection within the pancreas. Gastrinomas are usually seen in relation with the pancreatic head region. Your VIPomas and your glucagonomas are seen in relation to the pancreatic tail, and the rarest of them, the somatostatinomas, are seen in relation with the pancreatic head. Now, the genetic basis of many of these tumors are now well studied, and the well-differentiated lower grade tumors in general have associated MEN1, mTOR genes, ATRX and DAX gene mutations, with ATRX and DAX gene mutations, which are generally associated with the higher grade 2, grade 3 well-differentiated tumors. Whereas your neuroendocrine carcinomas, which are poorly differentiated, have a higher association of your TP53, retinoblastoma, KRAS, and SMAD4. Now, coming to imaging. Now, imaging plays an important role mainly in detecting these lesions, specifically in patients who have presentation with a clinical syndrome. Many of these tumors, as I told, are non-functioning, and many of these are detected on imaging for some other purpose as well. In patients who have clinical syndrome, you need to localize these tumors, characterize not only based on enhancement, not only the type of tumor, but also the grade of tumor, whether they have any features that tell that they are likely to be malignant, and if so, whether it is resectable, the loco-regional spread of the tumor, extent of the disease, including metastasis, which most commonly occur to the liver. And you need to differentiate these neoplasias from other pancreatic lesions, in addition to the more common adenocarcinoma as well. Now, to aid in this imaging, you have the preliminary imaging of ultrasonography and endoscopic ultrasound. You have cross-sectional imaging of CT and MR, with all these three serving the anatomic imaging purpose. You also need, in addition to this, to increase your specificity of diagnosis, the aid of functional imaging modalities of SPECT and PET CTs as well. Now, coming to ultrasonography and endoscopic ultrasonography, in general, with the use of transabdominal ultrasound, the problem is basically visualizing your entire pancreas. And as I said, because many of these tumors are functioning, they are detected very early at a size that is less than maybe even 2 centimeters or even 1 centimeter. So detecting these tumors in the pancreas, especially when there is bowel gas and because of physique of the patient, is always a challenge. But nevertheless, if seen, these tumors are mainly hypoechoic, may have heterogeneity as the grade increases. You may be able to also demonstrate increased vascularity on assessment in your Doppler as well. In addition, you need to also evaluate for metastasis that most commonly occur to the liver. And most of these metastases are in general hyperechoic in nature, but can have your targetoid or hypoechoic patterns as well. Endoscopic ultrasound is one modality that can even detect occult lesions that are not detected even in CT. Now, the advantage in addition to visualizing these lesions clearly in endoscopic ultrasound is that based upon your contrast enhanced ultrasound, you can differentiate between a well-differentiated NET versus a poorly differentiated neuroendocrine carcinoma. And the rule is that if you are seeing significant arterial enhancement in any modality, whether it be contrast enhanced ultrasound, whether it be your cross-sectional imaging in CT and MR, arterial phase hyper enhancement means that you're actually dealing with a well-differentiated neuroendocrine tumors, whereas a poorly differentiated tumors, or as the grade of tumor actually increases, the degree of arterial enhancement actually goes on reducing. In addition to that, EUS will also help you in sampling these lesions, because unless you sample these lesions either via CT guidance or ultrasound guidance transabdominally, or most commonly via EUS, you're not going to treat these tumors based upon the HPR, because just based on imaging treatment is not always advisable. You can also use intraoperative ultrasound, wherein you can look at the relation of these tumors with relation to the adjacent pancreatic duct, as well as the vessels, so as to decide between an extensive pancreatic resection versus just an enucleation if they are well away from vessels and pancreatic duct, thereby avoiding your pancreatic fistulas as well. Now, CT by far is the most commonest imaging modality that is done for evaluation of neuroendocrine tumors, because of the spatial resolution of the imaging modality. We generally use a triple phase CT with an arterial, parenchymal, as well as a portal venous phase. And as I mentioned for contrast enhanced ultrasound, your lower grade tumors, your grade 1, grade 2, well differentiated tumors will have relatively a small size. They'll be well circumscribed and they'll show intense homogeneous enhancement, whereas your higher grade tumors will be larger and ill-defined margins. The enhancement will actually go on reducing. It will be heterogeneous enhancement that is there within the tumor. And your neuroendocrine carcinomas will usually also have, like your adenocarcinoma, may have involvement of your pancreatic duct with resultant pancreatic duct dilation. Now, to reiterate the fact, so the grade of tumor can be predicted in a way based on the CT post-contrast images, wherein if you're seeing a small lesion which has homogeneous enhancement, you're relatively sure you're dealing with either a grade 1 or a grade 2 well-differentiated tumors. As the size of the lesion goes on increasing, as the heterogeneity goes on increasing, means that you're dealing with a higher grade tumor. Also, as the degree of enhancement goes on decreasing, again, you're thinking in terms of a higher grade tumor. In addition to this, you have an indirect marker of this tumor being a high grade if you are demonstrating metastatic deposits within the liver, which will also be very small arterial hyperenhancing lesions, as in this case scattered in both lobes of liver. So these metastatic deposits can also be seen more commonly in your neuroendocrine carcinomas, or in general, the higher grade varieties of your pancreatic neuroendocrine tumors. So this was a 32-year-old female who had recurrent episodes of syncope with documented hypoglycemia with a suspected insulinoma. So CT showed this homogeneously enhancing tumor in relation to the pancreatic neck, which is also demonstrated in the coronal sections here. Now, this lesion shows hypo enhancement in the subsequent phases, which relatively means that you're dealing with a low-grade tumor, or because of the associated clinical syndrome and insulinoma. Now, the terminologies of insulinoma, gastrinoma, etc., does not actually come forth in your pathologies, because staining for these particular tumors actually cause a lot. And many of the centers don't rely on staining, because for management purpose, it does not mainly rely on your histopathological diagnosis of your insulinoma or gastrinoma. It mainly depends upon the differentiation, whether it is a grade 1, grade 2, or a grade 3 tumor, along with the differentiation. So this was another patient who presented with recurrent abdominal pain, gastritis symptoms, and diarrhea, which again shows an arterial phase enhancing lesion in relation with the pancreatic head region. So these are typical locations, as I mentioned earlier, commoner locations for your gastrinomas. And gastrinomas have a predilection to what is known as the gastrinoma or the Passaro triangle. Now, this is formed by the junction of your cystic duct and CBD with the pancreatic head and neck, and a line that goes through the second and third part of the duodenum. So your gastrinomas are centered in and around your duodenum and the pancreatic head. And incidentally, if you look very carefully, you will see that this patient particularly also has an enhancing smaller lesion in relation with the lateral wall of the duodenum in this location, the small lesion here as well. So this was a case of possibly a multiple gastrinoma as well. Now, coming to MR, in general, you require the basic sequences that you require for your MR is your axial T2 and your T1, wherein most of your neuroendocrine tumors will be T2 hyperintense and T1 hypointense. The use of diffusion weighted MR and your contrast enhanced MR are two sequences that will help you, as in your CT post contrast, to grade your tumors. So higher grade tumors, as in all parts of in all other parts of the body, will show much more of diffusion restriction. You require additionally your MRCP in order to delineate the pancreatic ductal anatomy, in order, again, as in your intraoperative ultrasound, to decide on what exactly, whether the patient requires an extensive pancreatic resection or just an enucleation if the tumor is well away from the pancreatic duct. So this was a patient who had a tumor involving the pancreatic body, which was T2 hyperintense in the MR, with post in the diffusion images that shows diffusion restriction of the lesion, with post contrast images showing significant arterial phase enhancement and hypo enhancements, consistent with, because there is a diffusion restriction of possibly at least a grade 3 well differentiated tumor. So it's basically a higher grade tumor. Because of the relatively smaller size and well defined margin, it probably may be a grade 3 well differentiated pancreatic neuroendocrine tumor. I'll briefly touch upon scintigraphy just for completion, because a subsequent speaker will actually deal with it in detail. Because most of these tumors have plenty of somatostatin receptors, you have the role of somatostatin receptor scintigraphy with indium as an agent that will actually, when coupled with octreotide, which is a somatostatin analog, bind to these tumors and show increased uptake on your SRS scintigraphy in SPECT, and much more with better spatial resolution with various PET CT tracers. The most commonly used one, the gallium dotate scans, which will show increased uptake in neuroendocrine tumors. Now, these scintigraphic studies can also be used to grade your tumors as in your post-contrast, because in general, if you use an FDG PET CTs, if there is increased uptake in FDG PET, that means you're dealing with a higher grade tumor, because higher grade tumors in comparison to your lower grade will have lesser number of somatostatin receptors. So they'll show more of FDG uptake, whereas your dotted scan tracers will usually take more uptake if it is a lower grade tumors. And that's why there is a role for your dual tracer PET CTs to grade your tumor. You also have specific markers like your DOPA PET CTs and your GLP-1 receptor PET CTs, which are specific markers that may pick up your insulinomas in your scintigraphy. Now, based on imaging, it is important also to differentiate between your grade 3 pancreatic neuroendocrine tumors, which are the well-differentiated tumors, from the grade 3 pancreatic neuroendocrine carcinomas, because management and prognosis actually is different for either of these groups. So in general, your neuroendocrine carcinomas will be larger, ill-defined, and ductal involvement will be there. Metastasis will be present. There will be heterogeneous enhancement, and there will be hypoenhancement with more amount of diffusion restriction. And with the use of scintigraphy, as I told, there will be higher uptake of your FDG in your neuroendocrine carcinomas because there will be paucity of your somatostatin receptors. So thereby your dotted scans or your somatostatin analogs will not show much of uptake when compared to your well-differentiated neuroendocrine tumors. Now, coming to the category of your collision tumors within this group, the mixed NENs, they will contain both endocrine and non-endocrine cell types. And generally, these are very aggressive tumors. They are generally considered as grade 3 tumors, and histopathologically have got a ductal and an acinar type. Now, the tissue sampling of these tumors are very important because your treatment actually depends upon what specific component, whether it is the endocrine component or the non-endocrine component, that actually is the primary lesion or that causes metastasis, is one thing that determines the treatment of these patients. Now, based on imaging to differentiate these from your higher grade tumors, it's always difficult because these tumors, like any of your higher grade, especially your neuroendocrine carcinomas, these are very similar to that. They will be very large local invasion. Your distant metastasis and lymphadenopathy will always be seen in these aggressive tumors. Now, there are a lot of syndromes, even though it's a minority, that have an associated pancreatic neuroendocrine tumors, the commonest of them being MEN1. So if you see a pancreatic neuroendocrine tumor in relation with a parathyroid adenoma or a pituitary lesion, you need to consider a syndrome underlying cause like your MEN1. You can have pancreatic neuroendocrine lesions even in BHL syndrome, in your neurofibromatosis type 1. You can have pancreatic neuroendocrine lesions also in tuberous sclerosis, with the caveat that pancreatic neuroendocrine neoplasm are not the most commonest pancreatic lesions in any of these underlying syndromic things. You can also have glucagon cell adenomatosis, which is also a syndrome that is associated with pancreatic neuroendocrine neoplasms. Now, coming to the differentials, any of your pancreatic lesions are always differential for your pancreatic neuroendocrine tumors. The commonest of them being your pancreatic ductal adenocarcinoma. So if you are seeing an arterial phase hypoenhancing lesion that shows enhancement more towards the delayed phase, there is involvement of the pancreatic duct, IHBRD, you see lymphadenopathy and perivascular infiltration. That means that you are dealing more likely with a pancreatic adenocarcinoma. Metastasis is one thing that is with only your CT imaging, you cannot differentiate, especially in patients who have a history of a primary tumor. And that too, more commonly, your renal cell carcinomas, your thyroid and melanoma history. If you're seeing an enhancing lesion in the pancreas, metastasis from these primary should always be a thing that you should always keep in a differential. And sampling is needed in addition to maybe even your scintigraphic studies that can actually help in reaching a diagnosis. All your cystic neoplasms, because your neuroendocrine tumors can show cystic degeneration, necrosis within, are also differentials, especially your serous cyst adenomas or cyst adenocarcinomas, wherein your microcysts, because they are very small and clumped together, may actually mimic a solid area and create problems. But again, your scintigraphy is one area that will help you in making a diagnosis in addition to the morphology in your MR images. Accessory splenic tissue within the pancreas, or what is known as a splenu within the pancreas, is also 1DD because it will enhance in the arterial phase, but the differentiation is based upon enhancement pattern similar to that of your splenic tissue in the arterial and subsequently in the venous phase. You can also take the aid of your sulfur colloid scintigraphy because that is something that will be taken up by your splenic tissue. Your other DDs like your GIST and paragangliomas that are seen in close relation with the pancreas are also differentials. in addition to your splenic arterial loops, which may be mistaken to be neuroendocrine tumors in your axial, wherein your MPRs may help you in reaching a diagnosis. Now, coming briefly, I'll superficially touch upon management as well. The most important determinant in management is tumor grading and differentiation, for which definitely a biopsy is indicated. This becomes the primary determinant for your treatment, in addition to your staging. So the latest staging was followed is the AJCC 8th edition that has been adopted in 2018, with all your well-differentiated neuroendocrine tumors stage as per the neuroendocrine tumor staging system, whereas your grade 3, that is your poorly differentiated pancreatic neuroendocrine carcinomas, will be staged as per your pancreatic adenocarcinoma staging. So whenever a patient comes with a suspected pancreatic neuroendocrine neoplasm, you need to evaluate for a clinical diagnosis whether the patient has got an underlying clinical syndrome, like for a functioning neuroendocrine tumor. You need to objectify it based upon the laboratory test. So you do neuroendocrine markers of your serum synaptophysin and chromogranin. You do all your other tumor markers, and you assess for hormone levels to get an objective assessment of a correlate of your clinical syndrome. And you do imaging in order to detect and characterize these lesions. The ultimate purpose is to do a grading and staging, with many of the imaging characteristics that I've already explained, helping in making a primary grading of these tumors, which eventually will require your biopsy and histopathological assessment. The staging will primarily depend upon your imaging per se. So based upon your grading and your stage, in general, all your neuroendocrine tumors, if they are functional, need to be resected in addition to control of symptoms. If it is non-functional, up to less than 2 centimeters, you may wait and have a follow-up criteria. Whereas more than 2 centimeters, you need to go ahead and resect even non-functioning tumors. So your well-differentiated grade 1, grade 2 tumors, depending upon your size and functional assessment, you can actually have either a conservative or a resection. Your well-differentiated grade 3 require resection, even if in advance they require better is to go ahead and do a debulking. In addition to drug therapy, because many of these have got mTOR receptors, there are mTOR antagonists like your everolimus, sirolimus that can be used, and something that is called as a peptide receptor radionuclide therapy, which will also be discussed in detail by the subsequent features, which are options in your well-differentiated tumors. Your poorly differentiated tumors also, there can be surgery if it is localized and debulking if it is advanced, with chemotherapeutic drug agents like cisplatin, etoposide as options in management. In addition, you also have interventional radiological procedures for metastasis, more commonly to the liver, with regards to your ablation, TACE, and TARE. I will briefly touch upon, before concluding today's session, on the relatively recent developments of the relatively newer things that we have less heard of. So grading of tumor is very important, and imaging, does it play a role? Yes, in future it will definitely play a role. With the advent of radiomics, you now are able to actually find out patterns in your post-contrast CTs which will pertain to a particular grade of tumor. So what is known as your CT texture analysis, that gives you umpteen number of parameters based upon which you can actually predict your WHO grade of tumors, not only of pancreas, but everywhere in the body as well. The same texture analysis can also be used in MR as in CT. You can also use MR diffusion ADC histogram based analysis, where a lot of papers that have come out which have actually given cutoffs for your low grade and your higher grade tumors, but they're not generally validated as of now for your general practice largely. You also have studies that have used specific contrast agents. There are studies that actually tell that analysis on your hepatobiliary phase may actually detect much better your neuroendocrine tumor mets to the liver, wherein it appears as hypointense because they don't have the normal hepatocytes within them. Now, this is not a relatively recent development. This is something that was actually done very previously, but relatively unheard to most, I believe. This localization of tumors, either intra or pre-op. Now, insulinomas are tumors which can be very small and difficult to localize. The issues were prior mainly to the development of high slice multi-detector CTs, wherein localization of these insulinomas were always a difficulty. So what was actually done earlier as one of the options is to selectively cannulate your pancreatic arteries from the head, which supply your head separately, your body separately, and the tail separately. Each will be cannulated separately, and you will instill calcium into these arteries specifically. And once you inject calcium, you will detect the amount of insulin within the hepatic vein. So depending upon which artery is stimulating the insulinoma, that part of the pancreas used to be resected surgically. And also, in addition to that, you could also embolize that particular artery prior to surgery, or you can put in methylene blue through that particular artery so that identification used to be better intra-op. So with that, I stop. Thank you.